Good morning, everyone. Today we discuss on a randomized phase 3 trial comparing Nimotuzumab plus Cisplatin chemoradiotherapy versus Cisplatin chemoradiotherapy alone in locally advanced head and neck cancer. So, head and neck cancer burden in India, that an analysis from published out of 37 population-based cancer registries. So, in India, more than 65% of patients with head and neck cancer attend the hospital with a locally advanced disease. The all-site cancer incidence rate was 103.7 and 102.4 for 1 lakh population in males and females. But the age standardized incidence rate for head and neck cancer was 25.9 and 8 for 1 lakh population for males and females, respectively. So, locally advanced diseases include advanced T stage and advanced neck disease, that is N2 or greater. But these cancers are closely associated with tobacco and alcohol use, but a growing proportion of squamous cell carcinoma of the oropharynx that are associated with HPV. And HPV positive tumor have a higher cure rate than HPV negative. So, tumor with HPV has a strong and independent prognostic factor for survival with oropharyngeal cancer. And on the basis of a phase 3 RCT, concurrent chemoradiotherapy has been established a preferred standard of care for a non-operated locally advanced squamous cell carcinoma of head and neck cancer. But survival benefit of adding chemotherapy to radiotherapy of a 6.5% at 5 years and an approximately 13% improvement in the local regional control. Most common standard for chemoradiotherapy regimen is RT plus hydrocisplatin 100 mg per meter every 3 weekly. Based on retrospective data, minimum 200 mg per meter square cisplatin is optimal, and the weekly schedule of 40 mg per meter square and every 21 days schedule 100 mg per meter square, both are commonly used. Another option for CTRT include a preferred regimen is a hydrocisplatin, and another is carboplatin plus infusional 5FU, that is a category 1 recommendation. Another recommendation is a recommended regimen is a weekly cisplatin 40 mg per meter square, carboplatin paclitaxel. Another is a docetaxel, that is if patient is a cisplatin ineligible. Other is a cetuximab, cisplatin or infusional 5FU, or cisplatin or paclitaxel. In open label non-inferiority phase 3 RCT, that weekly versus 3 weekly cisplatin and the radical radiotherapy in locally advanced head and neck squamous cell carcinoma, that is a concept trial. This is the multicentric non-inferiority RCT that compared cisplatin 100 mg per meter square versus 40 mg per meter square weekly. That is with 7 times with concurrent RT as a definitive therapy in a non-nasopharyngeal locally advanced head and neck squamous cell carcinoma cancer. Primary objective was 2-year local regional control rate, and secondary endpoint is to include OS or PFS, toxicity, and compliance. So between April 2018 and January 2021, 278 were randomized. Median age was 56 years, and most common site are oropharynx. And TNM stage most common are stage 4A. 13% oropharyngeal who were tested for P16 were found positive. So there were more treatment delay in a treatment arm, that is a cisplatin 3 weekly, and local regional rate at 2 years were 57.69% in the cisplatin arm, that is a 3 weekly, and 61.53% in a T arm. T arm is a weekly schedule with an absolute difference of 3.84%. There was no significant difference in the median time to local regional failure, and with OS is in C arm is a 30.50 months and T arm is a 25.46 months, and also PFS is in C arm is a 20.60 months and T arm is a 20.66. So this trial confirmed that concurrent CTRT with weekly cisplatin is a non-inferior to 3 weekly cisplatin, and that is a better tolerated with a less interruption, hospitalization, and toxicity, and should now be considered as one of the standard. Or that is one is a weekly cisplatin with 30 mg per meter square versus every 3 weekly cisplatin. That is also non-inferior trial, non-inferiority trials, but that is a 30 mg per meter square cisplatin is inferior to weekly 3 weekly cisplatin 100 mg per meter square. And another JCOG 1008 is a SAM trial, that is a weekly cisplatin 40 mg per meter square versus 3 weekly, that is a non-inferior. Another option is a cetuximab. So cetuximab with adding concurrent chemotherapy with radiotherapy for locally advanced head and neck cancer, that is a GORTC 2007-001 phase 3 randomized trial. They include randomization of arm A include radiation plus cetuximab plus carboplatin or 5FU infusion, and another arm B is with only cetuximab. In this phase 3 randomized trial, patient with N0 to 2B non-operated stage 3 or 4 cancer, the addition of cetuximab to RT was similar in both arms, with a loading dose of 400 mg per meter square at day 7, followed by weekly dose of 250 mg per meter square. And concurrent chemotherapy consisted of 3 cycles of carboplatin that is a 70 milligram per meter square per day on day 1 to 4 and 5 to 600 milligram per meter square on day 1 to 4 with continuous infusion. So P60 positive immunostaining was found in 21% of tumor in each arm, and significant improvement in PFS was found in a patient with a P16 positive compared with P16 negative oropharyngeal cancers. And a significant improvement in a PFS was observed in favor of the chemotherapy plus cetuximab RTM in patients with a P16 negative oropharyngeal cancer, as well as in those with a P16 positive oropharyngeal cancer. So the addition of concurrent chemotherapy to cetuximab and RT that improve PFS and local regional control in patients with oropharyngeal cancer, regardless of the P16 status. But there is an increased side effect with the addition of carboplatin 5 with the cetuximab, mainly neutropenia. So HPV in oropharyngeal cancer. So HPV infection in the etiology of oropharyngeal squamous cell carcinoma was first found by Wilson et al. And that HPV positive patients tend to be younger with a median age of diagnosis of 54 and less exposure to tobacco and alcohol and higher socioeconomic status and education. For HPV positive tumor more likely to present with early stage and higher end stage, usually cystic and multi-level. So why does HPV positive oropharyngeal cancer have a better prognosis? So HPV positive tumor may harbor fewer or different genetic alteration and also have a higher radiosensitivity, probably due to intact apoptotic response to radiation. The absence of field cancerization or immunological response that also play a role in improved response. Also, younger age, good workman status, fewer comorbidities of HPV positive oropharyngeal cancer patients may also contribute to improved survival. And overall survival rate increase with HPV positive status, low EGFR, and high P16. Another option is a nimotuzumab, that is in combination with the intensity modulated radiotherapy and improved survival in locally advanced head and neck cancer. So this is a China study between January 2015 to December 2018 from 8 hospitals. That the median follow-up time was 54.2 months. The addition of nimotuzumab was associated with improved OS and also improved significantly advantageous PFS. So the addition of nimotuzumab with IMRT treatment may provide both OS and PFS benefit for locally advanced head and neck squamous cell carcinoma, particularly those with a stage 4 and 2 disease without previous surgery and receiving radiotherapy 6 or more than 6 weeks and with concurrent chemoradiotherapy. Another is a docetaxel as a radiosensitizer in patient with head and neck cancer. That patient is unsuitable for cisplatin. That is a patient cisplatin ineligible patient. So this was a randomized phase 2-3 study with adult patient age 18 or more than 18 years with locally advanced head and neck cancer, chemoradiation, and echo performance 0 to 2. In patient is a cisplatin ineligible, where randomly assigned between 1:1 to radiation alone or RT with docetaxel 15 milligram per meter square weekly. Primary endpoint was a 2-year DFS. The median OS was 15.3 months in RT alone arm, and RT with docetaxel is 20.5 months respectively. And the 2-year DFS was 42%, 30% in the RTM and 42% in the RT and docetaxel arm. But with that, addition of a docetaxel, that is an increased toxicity with a grade 3 to grade 5 toxicity like mucositis, odinophagia, dysphagia, and maculopapular rest. That is a more common with the docetaxel arm. Thank you.
Thank you, Mahesh, for a detailed discussion of all the options available. We'll see this article and we'll come to the discussion part where we'll discuss all of this. So let's go ahead with the methods and patients and methods section. Yes, share हो गया है. You can make it full screen. We can start.
Audible, sir. Go ahead.
Yes.
Comparing nimotuzumab CTR head and neck cancers. This was a phase 3 open label RCT investigator initiated conducted at Tata Memorial Center, and we had screening for this. Mostly locally advanced head and neck squamous cell cancers arising in the oropharynx, larynx, hypopharynx, and oral cavity were taken, and they should have a life expectancy at least about 6 months with Karnofsky performance status above 70, above equal to 70, and adequate hematological, renal, and hepatic function defined as ANC more than equal to 1.5 thousand per microliter, HP more than 9, and platelet more than 1 lakh, and renal function with the calculated EGFR more than equal to 45, or serum creatinine less than 1.5, with hepatic function was mentioned as bilirubin less than equal to 1.5 upper limit of normal, and AST/ALT less than equal to 5 times upper limit of normal. And the females who were screened had to have a negative UPT. And in the exclusion, we had patients with tumors in the nasopharynx, salivary gland, nasal cavity, and who had received prior immunotherapy or prior radiotherapy to the head and neck region, or prior malignancy other than non-melanoma skin cancer if they had distant mets, even if they had a suspected or known hypersensitivity to similar biological agents. For example, trastuzumab they had cited in the protocol. Pregnant lactating women were excluded, or uncontrolled intercurrent illness, whether diabetes, hypertension, were excluded. Known HIV or active viral hepatitis were excluded, and if they received prior therapy that targets EGFR pathway, they were excluded. Before randomization, comprehensive testing like head and neck examination, blood tests, imaging of the head and neck region, either CT, MRI, along with chest X-ray, ECG, pure tone audiometry, nutritional profile, speech, swallowing, and dental assessments, and the deficiencies were managed accordingly. And if there was a nodal staging of N2, then PET-CT was done to rule out distant mets, and biopsy was done prior to starting the therapy again. And in addition to that, HPV testing with the IHC for P16 was also done. And these were like the baseline characteristics in the two arms, which was fairly matched: age, sex, performance status, and substance use sites, and TNM staging, and the histological grade and HPV status were fairly matched in both the arms. And in the randomization, it was a stratified block central randomization for 5 factors which were used: sites of malignancy, stage, age, radiation technique, and treatment center, but the final analysis did not include any treatment center. The radiotherapy details, they received a 70 grays in 2 gray per fraction 5 days a week if the lymph node and tumor involved regions, and the uninvolved nodal regions were given 46 to 50 gray radiation. Chemotherapy, cisplatin, a weekly dose was given, 30 mg per meter square, along with supportive medication. Nimotuzumab was a flat dose, 200 mg given in 250 ml/ms over 60 minutes. No pre-medication was used. These were the visits 3 to 8. About 7 weeks of cisplatin or nimotuzumab with cisplatin was given. Post CTRT, they underwent a comprehensive clinical examination and PET or CT after completion, after 8 weeks of completion. And thereafter, there was a 3-monthly follow-up for 2 visits, and then the 6-monthly follow-up for 4 more visits. And in these visits, there were also imaging done if residual or recurrent disease was there, or they were offered a surgical resection, or if there was a residual progressive or recurrent disease, there was also a pathological confirmation through biopsy. And if they were not willing to undergo any surgery or unresectable disease, then they were offered palliative chemotherapy. Post 2 years, again, there were 6 visits, 6 monthly. And in these visits, there were no imaging, just clinical evaluation and labs. And also, if there was a progression, they were followed up telephonically for every 2 months. This shows the entire study design, where about 754 patients were tested for eligibility, and there were 218 which were excluded, out of which there were 143 not meeting the criteria. Then 536 were ultimately randomized, 268 in both the arms. And after the therapy, the analysis was done. So the primary endpoint was the progression-free survival, which was defined as the date from randomization to the date of disease progression as per the radiological RECIST 1.1 criteria. There were other endpoints which included loco-regional control. This was defined as time between date of randomization and date of loco-regional failure. And disease-free survival, this was defined from the time of treatment completion only. After treatment completion, when the patient experienced complete remission. In complete remission cases, the date from response assessment to the date of recurrence was taken as disease-free survival. And if there was any recurrence and salvage surgery was offered, then DFS was calculated from date of salvage surgery to again date of recurrence. Overall survival was taken as date of randomization to date of death. Adverse events was graded as per CTCAE version 4.03, and multivariate analysis was done for PFS, DFS, LRC, and OS with non-prognostic factors which were used: age, site, stage, and ECOG performance status, and radiation technique EBRT versus IMRT. And HPV status was another factor which was used in the subgroup analysis. So here we have the PFS curve. We can see that the 2-year PFS was 50.1% in the CRT arm and 61.8 in the NCRT arm, had a hazard ratio of 6.69 with confidence interval 0.53 to 0.89. And PFS was significantly longer in patients who received the NCRT, and also a non-oropharyngeal site of primary malignancy and stage 3 disease also improved the PFS. The PFS subgroups, we can see age, site, stage, radiation technique were the sites used. And in all of these, the plot shows that the Nimotuzumab is showing a better results. Disease-free survival, again, the addition of Nimotuzumab decreased the hazard of disease recurrence by 29%. And the hazard ratio was 0.71 with 95% confidence interval 0.55 to 0.92 with p-values significant. The 2-year DFS was higher in the NCRT arm, which was again 60.2%, 2 years, and 95% confidence interval was 53.6 to 66.3. Compared to the CRT arm, it was 48.5% with 42 to 54% 95 confidence interval. The results of the sensitivity analysis again showed the p-value significant, and they were in concordance with the above mentioned results. Loco-regional control, we can see the 2-year loco-regional control was 57.6 in Cisplatin and 67.5 in Nimotuzumab Cisplatin. Hazard ratio was 0.67, 95% confidence interval was 0.50 to 0.89. So again, this was mentioned to be significant, 0.006, and even it was significant in patients who received cumulative dose of cisplatin more than equal to 200 mg per meter square. Overall survival was, the 2-year overall survival was 63.8 in Nimotuzumab and 57.7 in the CRT arm. This was again not significant, but however, if there was stage 3 disease, they had improved OS, which was significant. In the adverse reactions between two groups, most of them had similar rates. However, when we see mucositis, there was one p-value which was significant. The rest of the side effects were fairly distributed, and hyponatremia was another one which was quite common, other than mucositis. So this is just the compliance. Most who received 7 cycles of cisplatin, and 34 and 35 were discontinued because of toxicity. The radiotherapy details and the side effects were entailed. Most were very compliant. If there was residual disease after the CTRT, sometimes salvage therapy was offered. and this included 72 patients, 34 in CRT and 38 in the NCRT arm. The CRT 22 underwent the salvage surgery, and which were the surgeries? It was mostly lymph node dissection in 16, local excision in 2, and both local excision with lymph node dissection in 4. And in the NCRT arm, 26 underwent salvage surgery, 5 progressed before salvage, and 7 refused. And among the 26, 13 patients underwent lymph node dissection, local excision in 1, and local excision with lymph node dissection in 12 patients. In the subgroup analysis and how it was conducted, we have 536 patients overall in the study. 269 had primary oropharynx, and in that P16 testing was feasible in 212. 187 patients were P16 negative, 187 were negative, and these were included in the analysis, 91 and 97 in both the arms. So here we have the baseline characteristics of all of them. They were fairly matched in all of the, and it also shows the difference in the survival and progression here. In the statistical analysis of these 187 patients, type 1 error of 5% and type 2 of 20% was considered, and the subgroup was powered to rule out a 20% absolute improvement at 2 years PFS, in which was the primary endpoint. Kaplan-Meier method was used to estimate, and 95% confidence interval were reported, and p-value of 0.05 or below was considered significant. These were the results in the subgroup analysis. The local regional control, PFS, OS were all provided to be significant, but DFS was not coming out to be significant. So these are the curves for the subgroup analysis. So here median PFS was 12.9 months in cisplatin versus 35.3 in the nimotuzumab cisplatin. P-value was significant. And local regional control, it was again 17.3 months versus 60.3 months, cisplatin and cisplatin nimotuzumab arm respectively. Overall survival was also significant, 19 months in the cisplatin arm, while 35.9 months in the cisplatin nimotuzumab arm. And the issue was that the assumption of proportional hazard was violated in the overall survival. So they did a restricted mean overall survival in both the arms. And the arm 1 was the nimotuzumab cisplatin arm, which showed 37.6 months, and the cisplatin arm was 29.46 months. I'll let Vivek sir take over.
Discussion of this article. This is the first phase 3 study with nimotuzumab along with cisplatin, which showed increase in PFS when compared to cisplatin alone in patients with locally advanced head and neck cancers who received radical chemoradiation. And the addition of nimotuzumab improved 2-year PFS and decreased the hazard progression by about 31%. And the improvement, there is improvement in OS, but it is not significant. And however, the OS was not the primary endpoint of this study, and there is a trend towards improvement in OS. And as per in RTOG 0522 study, the subgroup analysis revealed that the addition of cetuximab in the study leads to trend towards improved outcomes in young patients and the patients with HPV negative status, and the patients of oropharynx and hypopharynx, and the patients with T4 stage tend to have improved outcomes when come with cetuximab. In our present study, HPV negative status is about 67.4% of patients, and oropharynx of 50.4%, and hypopharynx of 17.5%, and T3 T4 disease of 79.1%. In HPV negative status, the use of nimotuzumab in this cohort of patients lead to decreasing risk of progression by nearly 50%, which translates into decrease in the risk of death by 37%. And the proportion of patients who received a cumulative dose of cisplatin more than 200 mg per meter square, which is standard in this current study, is about 78.7% in CRT arm, and it's almost similar, 77.6% in NCRT arm. And the corresponding rates of rates in RTOG studies was and other major studies is ranged between 62.5 and 88.5%. And the limitation for this study is it's a single center study. The accrual took almost 6 years, and the certification is not according to HPV status, but the incidence of HPV status in our population is very low. And however, in both the arms, the HPV status is of similar percentage. And there is a disproportionate high number of hypopharyngeal cancers, but the hypopharynx carries a poorer prognosis in NCRT arm. And the dose of 100 mg per meter square 3 weekly was not used as the standard. Hence, the additional impact of nimotuzumab with this dose is unknown. Thank you, sir.
Randhir and Vivek. So we could see that there is an important trial run from our own institute that tells us about the importance of utilizing concurrent chemotherapy and targeted therapy at the correct time and the correct doses. So we have seen that 40 milligram per meter square is definitely superior to 30. That is what we know now.
Yes, sir.
There is a trial which showed that the AIMS trial and the CONCERT study which showed that 100 milligram per meter square and 40 milligram per meters are quite similar, non-inferior to each other. So now the standard of care is utilizing either 40 or 100. We do not utilize 30 mg per meter square unless until essential. If we start with 40 and it has significant toxicity, we can come down to 30. So that was the first point. So if we want to incorporate nimotuzumab, because the overall survival difference is very significant in the subgroup of HPV negative cohort. Can you show that overall survival analysis of HPV negative subgroup?
HPV negative.
Yes. Yes. So if we see this data, the median overall survival is 19 months in cisplatin alone, while it was close to 36 months in the cisplatin nimotuzumab. So it's clear that it's close to doubling of the overall survival, which can be achieved with the addition of cisplatin along with nimotuzumab along with cisplatin in the patient with HPV negative subgroups. From the RTOG study, we know that there are some other poor predictors of the outcomes, which include T4 disease, younger patients, and because these are known to have HPV positive status, HPV negative status, and we need to understand, we need to identify the subgroup of the patients where the outcomes are expected to be poorer, and addition of nimotuzumab to cisplatin 40 milligram per meter square would be considered. If we go by this data, and we add nimotuzumab, what we do now presently is that we do cisplatin 40 milligram per meter square along with nimotuzumab, and if patient develops significant toxicities including mucositis and other difficulties including reduced increased creat and reduced GFR, we tend to reduce cisplatin to 30. That is what we are doing presently. So it is important again to understand when to use, what to use. Concurrent chemotherapy can lead, selection of concurrent chemotherapy and targeted therapy can improve the outcome significantly. There is data for docetaxel with RT also, which we have, which is again from our own institute. That is a complete different discussion, so I'll not going into the detail of that, but just to highlight, docetaxel, when added to cisplatin ineligible patient specific subgroup, they are also leading to significant improvement in the outcomes, including overall survival. And the outcomes in cisplatin ineligible is much poorer than cisplatin eligible itself. Toxicities, we always say that docetaxel leads to significant toxicities. Yes, it will lead to toxicities, but it is important to understand and to learn how to manage them and when to de-escalate. So 15 mg per meter square was the starting dose for docetaxel. We started 15, but whenever patient develops significant toxicities, we reduced to 12 mg per meter square. And now we are going to start a trial of 15 versus 12 also. That is now IC approved. And that trial will let us know whether 12 mg per meter square is non-inferior to 15 mg per meter square. So those are the things that we want to understand.
Sir, is there any study which compares nimotuzumab versus cisplatin alone?
So there is a study for
especially in
cetuximab.
patients if cisplatin is ineligible. In some of our patients, we'll use cetuximab alone with RT. So is there any?
So we have data of RT versus RT plus cetuximab in overall patients, that is cisplatin eligible and ineligible both, where it clearly showed addition of cetuximab is leading to improvement in the outcomes in these patients. But there is now data which was not covered here, which I wanted to cover, and good that you have brought about that point. If we compare cisplatin eligible patients and we give cisplatin versus cetuximab, there is clear data that cisplatin is superior to cetuximab. There is no data even which compared carboplatin to cetuximab. Even carboplatin was somewhat better than cetuximab in some subgroups. So it is important that wherever platinum is feasible, just foregoing the platinum should not be the way. So cetuximab alone or nimotuzumab alone, they are not very, they are good, but they are not so potent that you can omit cisplatin. So there was a de-escalate HPV trial. So in the de-escalate HPV trial, the patients who were HPV positive, they were given cetuximab versus control arm. In the standard arm utilized cisplatin. This was done to reduce the toxicities associated with cisplatin. But it was found that cetuximab arm had significantly inferior outcomes, and also toxicities were not so reduced. So cetuximab itself will lead to some significant toxicities, which are somewhat different from the cisplatin. Cisplatin causes more of renal toxicities in dyslipidemia, while cetuximab will cause more of skin toxicities and mucositis. The advantage with nimotuzumab, which we see as compared to cetuximab, which is a theoretical point, that nimotuzumab is having less tighter binding with EGFR. So it causes less amount of hypomagnesemia, less amount of mucositis. This is what we have seen and observed. There's no direct head-to-head comparison between cetuximab and nimotuzumab, but that is what we see. So that is why in this trial also, cetuximab was not utilized in combination with cisplatin. It was nimotuzumab and not cetuximab. So I request Amit Joshi sir to give his comments on this article and his.
Sir, can we use for every patient like standard of therapy with nimotuzumab with if patient is feasible?
So can you show the survival outcomes in HPV positive subgroup?
This is overall survival, sir.
Like
Yeah.
both groups combined.
Both groups combined. So if we see the combined overall outcomes, it seems that the overall survival was not much different, but that is because the study was not powered to demonstrate outcomes for overall survival. If the OS outcome would have been selected, the number of patients would have been much higher. It is already close to 500 plus patient study. So that is, and for OS proving OS, it would have required close to 400 patients in each arm. So that is why most of the time progression-free survival is taken so that the study can be completed. This study also took 6 years to accrue at a high volume center like TMH. So despite that, it took 6 years to accrue. So that is one point. So if we see the data for improvement in the overall survival, yes, we can utilize by going by the primary endpoint of the study. But if you have to understand where it will benefit the maximum, that is what is HPV negative subgroup. Patients with T4 disease, younger and fit patients who are likely to tolerate the combination. So these are the 3 points where we would like to utilize cisplatin plus nimotuzumab. The doses which we utilize now is 40 mg per meter square plus nimotuzumab. If a patient is developing renal toxicities, then we tend to reduce from 40 to 30 as per this trial. But we initially start with 40 instead of 30 because we want to achieve 200 mg per meter square. So that is the first requirement. If the patient is cisplatin eligible, you have to deliver 200 mg per meter square. That means if you're giving 40 mg per meter square, at least 5 cycles of 40 mg per meter square are mandatory. And if you are able to give timely, around 5 to 6 doses can be easily given. But what happens with 30 mg meter square, you will require 7 doses of cisplatin. So which is practically difficult in the real world scenario. And by whatever you give, most of the time you will be able to achieve 6, not beyond that with concurrent CTRT. So that is why we try to utilize 40 so that you can reach 200 mg per meter square as early as possible. And if you are having, if the patient is having significant toxicities, you reduce the dose to 30. So going by this data, the suggestion is to select the patients. All the patients might not benefit. There is improvement in the PFS definitely, but it seems to be driven by mostly the HPV negative subgroups, which that is why a separate subgroup analysis was done, and that was published separately, which we tried to include this discussion methods and background throughout. So that is the subgroup which we need to focus. And I think P16IHC is done already in all the cases of oropharynx as a part of reflex testing. If it is not done, when
No,
we
it
are,
is done, sir.
yeah. And if it is not done somehow, we can raise the requisition when we are starting the workup for CTRT, so that it is available by the time you decide the final protocol. Amit Joshi sir, if you are available for comments. Else will request Nandini ma'am.
Akhil,
Yes sir. Yes sir. Yes sir.
no, that was very nice discussion. There was a 10-year survival data which was presented in ASCO this year.
Yes.
That was, it didn't make a big noise, so I think so maybe no, the resident has missed it, and that could have helped a bit. But I totally agree with all the discussions. Very nice discussion. Yes,
sir. Sir, your comment, sir, how to take this data into the real practice, the combination of cisplatin plus nimotuzumab, like the our residents asked whether we should let all the patients, should we reserve it for the subgroups? What is your take, sir? And
I totally agree with what you said. HPV negative, high volume disease, high nodal burden. Those were the patients. These were the kind of patients included. If you see the proportion of patients, these were the patients included, and it's a fair conclusion, Akhil.
Okay, sir. Okay, sir.
Nandini, sorry, I interjected. My apologies.
No, sir. I agree with whatever the Akhil has said. In case we are not able to give 100 milligram per meter square cisplatin, and especially we have high risk patients such as HPV negative and T4 node positive, especially this group of poor prognostic, and we are considering weekly cisplatinum, then I think it's a good option to add nimotuzumab, like Akhil has already pointed out.
Any other comments from any of the residents or the query? So if there is no query, then we'll start some questions. So Rajmohan, unmute yourself. So we want to see, we want to see the differences of the toxicities. What is your take on the toxicities when you are explaining the patient? You are going to add nimotuzumab and the patient is willing for that. Patient asks what is the incremental toxicities with the additional treatment, because when you add some treatment, there will be some amount of incremental toxicities. So how will you counsel the patient and how will you justify the toxicities? For your help, this is there in the on the screen as well. Yes.
Yes, sir. I will explain that the toxicities of leukocytes would be more when compared to chemotherapy is CRT only on. So I will explain regarding mucositis, anti-mucositis measured to the patient, sir.
Okay. Okay. So so platinum, it is clear that when you are using cetuximab or nimotuzumab, they will add to the mucositis, because we know that it is EGFR directed monoclonal antibody. So they will add mucositis. That is known phenomena, and that is actually class specific toxicity whenever we are utilizing even in advanced head and neck cancer in the palliative setting as well. So mucositis is definitely increased. Proper hydration, as we learned from the docetaxel study, proper evaluation of the patient weekly, and if required when the patient is having maximum toxicity. So when we are expecting the maximum toxicities, anyone? Mahesh, would you like to suggest when the patients are expected to have maximum toxicity during CTRT?
Only at after third cycle of toxicity.
Yes. So when you are giving the third dose of your weekly protocol, after that time, the patient start to develop more amount of toxicity where it requires more careful attention. So it is a usual protocol now that if the patient is having some amount of increased toxicity like grade 2 mucositis already, it would be best to call the patients twice weekly instead of weekly to the OPD for assessment. because in the docetaxel study, we understood and learned that patients had suddenly developing toxicities, and if they were not interjected, they developed other toxicities as well. For example, reduced counts and others. So when the patient is after receiving third cycle of your weekly protocol, you should be more cautious and call the patients twice weekly if feasible, to discuss to observe the patient closely. And if the patient is tolerating it well, you can observe for 2 weeks, then you can again call back on the usual schedule. So this is one of the schedule which we utilize when we are adding something apart from cisplatin. In cisplatin 100 milligram per meter square, we already call the patients weekly to see about nephrotoxicity. We give post 2 days of hydration so that the patients do not develop increased nephrotoxicity, which is known to occur due to cisplatin. So every protocol has different set of toxicities, and we need to identify. It is not the usual every 1 week for all the patients. You have to call accordingly. For example, cisplatin 100 milligram per meter square is 3 weekly schedule, but still you will call the patient weekly and give hydration on day 2 and day 3 of giving 100 mg per meter square. On day 8, you need to see the electrolytes and RFT specifically. CBC might not be required, but electrolytes and RFT are mandatory. So it is very important. So I think this is the point. And when you are utilizing docetaxel, again, be very cautious. From week 2 and week 3 onwards, it is good to call the patient twice weekly if it is feasible. Nandini ma'am, your comment on this, docetaxel toxicities and the best way forward to manage these toxicities?
I completely agree. Frequent follow-ups, and when we used to initially have these toxicities when the trial started, and later on, we realized we used to call the patients every third day or alternate days to monitor carefully. And sometimes docetaxel causes unpredictable like dermatitis. You might see patients with radiation dermatitis grade 1, and after 2 days they'll come with a grade 3 dermatitis with entire desquamation. So it is very important, like Akhil said, to in regimens where they are more intensive and we are definitely using them for the benefit, we need to probably call the patients more frequently and monitor and hydrate them. Also, other thing is mucositis and aspiration. So we have to be on a lookout. Many patients are reluctant to get NGT inserted. So frequent follow-ups and basically reinstating that if they have significant dysphagia, get an NGT insertion done, maintain nutrition. Weight loss and hypoalbuminemia are two things which I noted was very common in patients who had these things. Toxicities were much more enhanced. So frequent monitoring of these parameters and frequent clinical evaluation, not just for 100 milligrams, also for docetaxel when we are giving, is very important.
Yes, ma'am. So that remains the key. Whatever we are doing, we try to improve the outcomes, but there will be some increased toxicities. So we need to counsel the patient and follow them more frequently. And if required, as ma'am suggested, timely insertion of the feeding tube is very important. And most of the patients are reluctant for the same, and they try to defer it for the next week. And when you are calling it more frequently and counseling.
Sir, are there any contraindications for nimotuzumab per se?
No, I don't see any direct contraindication. I think in this study also, if the patient is known to have some hypersensitivity event, which is not usually known till the time we start some monoclonal antibody, because these patients are usually treatment naive. In those situations, I don't think there is any direct contraindication, absolute non-contraindication. Any other comments or points by anyone? If none, should we end, ma'am?
Yeah, I think so.
Yeah. Thank you, Kumar sir, for the question.
Thank you.
I think there was a important question which was put up by Gautam and Nishant about the 10-year update, which did not show benefit of addition of cetuximab irrespective of P16. But sir had already replied that there is importance that this data had already showed a significant OS benefit at 2 years and 3 years itself, and the benefit is likely to be increased as we go down further follow-up. So definitely longer follow-up will be more helpful. But I think in the these are the early, in head neck cancer, when we see the recurrences, these are mostly in the early phases. So starting from 6 months to first 2 years, you get the maximum recurrences. And if the patient doesn't recover by first 2 years, I think most of the time the patient has salvaged patient is considered salvaged. So that is the most important part. Though there might be risk of the second malignancies, but most of the time the disease which was treated is considered to be cured after first 2 years. So that is an important point. So we should look at the local regional control remains a very important endpoint of these studies. And also there was an important point that most of the previous trials have included both HPV and negative, and there was a specific separate publication of HPV negative, which has made us more wise in selection of the patients and identifying the poor prognostic group so that the patients can benefit maximum without further increase in cost and the treatment poor outcomes. I think we can end now. Thank you everyone for the participating.
I have a small doubt.
Yeah.
Actually, our radiation department used to get that HPV testing done before the radiation. I don't know for what they used to get, but is there any outcomes regarding radiation per se with the HPV status?
So this is already proven that HPV positive have better outcomes. Previously, there were some multiple trials of de-escalating the treatment, but now there is clear data that you should not de-escalate treatment with the available data till now. But yes, the outcomes and the prognosis will be different. So you need to counsel the patients accordingly. So some patients who are HPV positive, they have chances of cure up to the tune of 60 to 70%. Patients having HPV negative subgroup, 5-year outcomes are not so good. So that is the importance of the counseling and how you are counseling the patients. So that is the important. It's an important prognostic group, but treatment for as per the radiation will be same till now. There is further studies ongoing. The initial studies have not shown any differences. That is why the de-escalate studies have failed. And initially it was thought that de-escalation will help for HPV positive group, but the de-escalation did not work. So it is important to take care of that.
Thank you, sir.
Thank you. Arnav, any comment?
No, sir, nothing additional, sir.
Okay.
And then one situation, so practically where we are using nimotuzumab, I think, which we have seen is where patients with severe renal impairment. I think we had one patient on dialysis where we gave the concurrent chemotherapy as nimotuzumab single agent. Not specifically contraindicated in that situation.
Yeah. So as it was highlighted, addition of EGFR-directed treatment leads to increased mucositis. And if you are able to intervene at the correct time by providing rice tube feeding or other, the patient will have reduced intake, and that will lead to definitely nephrotoxicity. So that is a known phenomena. So that is the importance of calling the patients and counseling them repeatedly for timely insertion of the rice tube. So that is very important. Mishra sir, your final comments?
So I think it is practically I use more than 20 patients in HBCH and also in combination. So it is feasible to give very easily, and we are totally correct that we should give stage 3 and HPV negative patients, and we can use more frequently in these patients and get more survivor. So feasibility is good, and tolerability with 40 milligram is also good. But we are giving, I think, 5 cycle of nimotuzumab and 6 cycle of platinum. We are following this schedule.
Yes.
Because most of our RT people giving 6-week radiation at Varanasi. That is and one thing for monitoring toxin, here our RT team is monitoring weight every week. So once the weight is decreased more than 5% or 10%, they are admitting the patients and managing them very aggressively. So we can also target that, take weight every week, or monitor intake at least verbally more than 2 liter, more than 3 liter. It can help us to detect the early toxicity.
Yes, sir. Thank you, sir. Thank you for the comments. So I think we can end now.